I'll present the case of a young woman that I saw and go over her orthopedic evaluation, so the verbal history, taking the orthopedic baselines and our orthopedic testing, and then I'll briefly touch on the course of care over our 7 visits. So her symptoms were diffuse. There are lots of symptoms. So headaches, historically a lot of TMJ symptoms bilaterally, chest pain, right arm pain, not below the elbow, right armpit pain, left armpit pain, left upper extremity symptoms all the way to the hand, neck pain, upper mid back pain, kind of diffusely across the neck and upper mid back. And she also reported that she had a loss of mobility in her upper extremities and she was really unable to work out like she wanted to. Symptoms, there was some incident about 9 months prior that had created the headache and the dizziness that was transient, lasted for a few seconds. And she attributes a lot of her symptoms to her posture, which she has been working on, especially having worked with a physical therapist prior to seeing me. So some of her symptoms were intermittent, some were constant in that if she pressed on her left armpit, for example, it was always really tender. What made her worse? So lifting the upper extremities, for example, doing stuff with the hair, reaching in certain directions like putting on a sports bra. A long work day could be provocative. Pulling mechanisms, so pulling on pants or socks would be aggravating. Computer work, sleeping was especially disturbed. She would remark that she often woke up with kind of like a crick in her neck and she couldn't even lie on her left side due to pain. So in terms of the care she'd already received, she'd seen a GP, an orthopedic surgeon. She'd been prescribed and taken muscle relaxants, meloxicam, Advil. She'd seen a physical therapist, she'd seen an acupuncturist, and they'd already done images in terms of X-ray and MRI of the cervical spine, which was relatively unremarkable. So that's her verbal history. And I have to say that coming out of the verbal history, it is, and I know I sound like a broken record, is screaming spine to me. What else would produce all of these diffuse symptoms other than spine? It doesn't sound like a ligament or a tendon or a muscle or anything very local. The pain is so diffuse that referral pattern could only be from the spine. So I'm already thinking there's a super high likelihood this is a mechanical joint derangement in the spine. Imaging has already likely ruled out red flags or something more structural in the spine. Anti-inflammatory treatments had been unfruitful. So I'm really thinking that this is a mechanical joint derangement in the spine. Again, I can't really think of what else it would be if it were musculoskeletal. Of course, it could be non-musculoskeletal, but that's exactly what I'm thinking coming out of this orthopedic evaluation, which makes me a little bit excited for patients because if no one understands or someone has seen prior clinicians, but those clinicians do not understand Robin McKenzie's work, and he ascertained that 70 to 80% of patients have mechanical joint problems, joint tweaks, if you will, where they're not moving correctly, and you can get them moving well by moving in a specific direction or two. If her prior clinicians didn't understand that, then I knew I could offer her something that was kind of a paradigm shift from what she'd already understood and already received care kind of surrounding. So that's her verbal history. When we get to the orthopedic baseline taking, which is part 2, I looked at neck mobility, thoracic mobility, and strength and a functional baseline. 4 orthopedic baselines. We're talking range of motion, strength, nerve tension, and functional baselines. Functional baseline meaning a movement, activity, task you can do in the clinic, hopefully, that will reproduce your problem, either your pain, your symptom, or a sign. Like, I can't get into this position. It doesn't hurt, I just can't do it. If we don't have something we can reproduce in the clinic, we just have to spend longer by using cause and effect analysis of doing that functional baseline at home, meaning it takes me 30 minutes of walking uphill to recreate my knee pain. Well, then I can't do that in the clinic. The patient will have to do it on his or her own. But those 4 things are the backbone of orthopedic evaluations. Some clinicians take a lot more. I don't use palpation testing because it's unreliable in most cases. In fact, I haven't used palpation testing in a long time. I'm sure there's a very specific niche that would need it, but it's unreliable for the most part. I don't do other kind of specific mobility tests. I take those tests as the baselines, and then I go on to kind of more diagnostic testing. So for her neck baselines, minimal loss with retraction with pain, pain with protrusion and flexion that were full. Right rotation had a minimal loss with pain. So other movements of the neck were full and not remarkable for pain. Again, there are 8 movements of the neck that I'm assessing. Thoracic spine, I just looked at the rotations for her. So we looked at right rotation and left rotation and sitting. Right rotation had a minimal loss with pain. Left rotation had pain. Thoracic rotation, the patient is sitting, and I ask them to go as far as they can, and I apply some overpressure at the end range to really assess for end range behavior of the thoracic spine into that plane of movement. For strength, I looked at shoulder flexion, abduction, elbow flexion and extension. I probably looked at shoulder IR and ER, wrist extension, thumb extension. They were all fine except for thumb extension on the left, which makes sense due to the symptoms going from the spine all the way into the left hand. So nothing remarkable there, nothing that would make me think muscular. I do not have patients lie down very often at all and test posterior muscles. You totally can. I just don't find it a useful part of my, useful use of my time when it comes to an orthopedic evaluation. But if I need to, I can do it in the future. But I'm not really testing I's, Y's, and T's in prone. So for the functional baseline, we use elevation of the left upper extremity. When she did it at a certain angle, it really reproduced her left armpit and left shoulder symptoms. So that was part 2, taking the orthopedic baselines. I did not take nerve tension on the evaluation, but I did subsequently look at nerve tension. Perhaps I didn't do it because of time. I don't really remember why, but I had so much information from this that I went on this. So part 3 of my orthopedic evaluation is testing. And for her, the only test I wanted to do was repeated movement testing. There was no orthopedic special test that I thought was germane to her situation at all. And so that's really different because other clinicians do not use repeated movement testing. I think Robin McKenzie's invention of repeated movement testing is the most important test we have in orthopedics. I wish more people used it and learned it, but unfortunately very few clinicians worldwide have learned his work very well. So we went to repeated movement testing on the evaluation. I looked at thoracic extension. We did 10, 20, 30, retest the baselines. I saw enough of an improvement in her baselines, mostly mobility and mobility with pain, to say that it was worth her time to do more thoracic extension over the course of the next 5, 6, 7 days. So her home program became thoracic extension over a chair, at least 10 repetitions, at least 6 times a day, continue to monitor posture. She already knew kind of all the tricks about posture, but we went over that again. It had been part of her care before, so she had learned about it and she was on board with posture. So she came back, visit 2, 80% better overall. Thinking that this is amazing, that's great. So my job on visit 2 is to assess, do we need more thoracic extension or have we got all that we need out of this specific movement? At some time, it may plateau. For some people, the first move you do gets them 100%. But for other people, it will get them 0%. And for others, it will get them 50 or 80%. And I say 0 because it can look good in the clinic. You do thoracic extension, everything improves. But then the more the patient does, there's just no carryover effect. So when I give a patient an exercise to assess over time, my goal is to pick the one that will most likely prove fruitful. But that's not always possible. It's not that easy for me to anticipate if you get better with 30, how will you do with 100 or 300? I do my best, but I don't know that answer. So the testing is, don't just do 30 in the clinic. The testing is do 100, do 300, and then we'll see how your body responds. That's why it's called repeated movement testing. And if you think about how joints move thousands of times per day, it just makes intuitive sense that you would need to challenge the joint with hundreds of movements for you to really gauge if it's the movement that's helpful or not. So again, 80% better on visit 2. I looked at more thoracic extension. It was not proving to be more beneficial. So I tested some other things and looked at neck retraction extension with overpressure over the chair and sitting. So moving up the spine a little bit in terms of the fulcrum of the extension. That had a positive effect, so that became the home program. She comes back and says, there's been no effect. I've done this neck exercise, there's been no change. So we looked at other movements. For some people, I'm looking just at one movement in the clinic, but for other people, we have time, the person's not that fragile or vulnerable or falling apart with different movements. I can test 2, 3, 4 different exercises with her. So for her, we looked at several things, including, I think, left side bending of the neck, prone neck retraction extension, possibly left rotation. But I got to supine neck retraction extension with overpressure on the chin off the table. That improved her baselines, and that became her home program after that visit. And by this time, the shoulder baseline was getting quite good. So I did end up doing nerve tension testing, the LVs test in supine. It was positive bilaterally, so we could use that to gauge for cause and effect with repeated movement testing as another baseline. But she went home with the supine version of extension of the spine. She came back better, not 100% yet, but about 90% or so. Again, my job is to retest that movement, see if it's fruitful to do even more. It demonstrated to us that it was not, so we looked at other things. I remember that we used a baseline in this visit of lying on the left side, because of all the things that had improved, 90% better on the whole, there were still some things that were still there, and some things that were still there quite obviously and painfully. And she was saying, I still just can't sleep on my left side in bed. So I had her lie on her left side. That became a really good baseline. We did some different testing of repeated movements. I ended up doing thoracic right rotation and sitting, grabbing the chair, really pulling into overpressure. And among the tests that we reassessed, go lie on your left side again, see if it's better. It was better. So thoracic right rotation became the home program. When she came back, she was 99% better, baseline's improving, neck moving well, thoracic moving well. I saw her again because she had tweaked her neck with working out as she was improving or increasing her tolerance to exercise with her trainer. And we did some simple retraction, which seemed to resolve it. So overall, I saw her 7 times. And I would say, you can say she responded to 2 or 3 specific movements. Thoracic extension and sitting, and supine neck retraction extension with overpressure off the plinth and supine are quite similar. They both gain the lower neck, upper thoracic spine. So they're both extension, they're different loads, and then right rotation of the thoracic spine is quite different. So I would say she responded to 2 or 3 specific motions. One of them got her 80%, but then we had to find the other movements that got that final 20%. So diagnosis of, lower neck and upper thoracic, or maybe just upper thoracic, joint derangement responding to extension and right rotation. This diagnosis is not really accepted in the orthopedic community, but it's a diagnosis that I find in 70 to 80% of people, that they have a joint problem that will respond to movement in a specific direction, and conversely won't respond to some movements, right? If I had given her flexion, I assume it would make her worse. But I could give her left rotation, had no effect. I could give her seated neck retraction extension, no effect. So directional preference movements are the ones that help, but there are other movements that are going to be not effective at all, have no effect, and other movements that might make the person worse. So that's kind of the crux of a joint derangement, is that it responds in a specific way. It's not just global movement. Maybe if you did every single movement you possibly could do, you'd get better because the good would outweigh the bad. But if you did every single movement you could think of, maybe the bad would outweigh the good. So that's why I'm usually almost always prescribing just one movement at one time. And again, this paradigm of thinking, of using McKenzie's repeated movement testing, is very different than the standard orthopedic paradigm. Standard paradigm is that on day 1, we use tests or we use images and we make a diagnosis, and then we're off and running with treatment strategies. I approach it quite differently these days. Yes, if someone comes in on day 1, I can tell you have a ligament sprain or muscle tear, we can start the appropriate treatment. But this scenario, and most scenarios that I deal with, I consider basically every appointment is like an evaluation. Every appointment is, what happened with this testing? Where do we go from here? So for repeated movement testing, I think the problem is a joint problem that's mechanical in nature, not structural, not inflammatory. I think there's a specific direction that you will need to get better. We need to work together to find that specific direction. And I can't just make that decision after 10 or 20 or 30 repetitions. We need to make that decision together after 200, 300, 400 repetitions. That's what the repeated part means. So again, every visit's kind of like an evaluation, but I'm going off of the information that the patient brings back. I did this 6 times a day like you asked. I made these lifestyle factor modifications like you asked, and this is what happens. And it informs where we go next. So with 7 visits, which I think is great for a presentation like this, but now we're done. There's no phase 2 or phase 3. It's working together to figure out what that movement is. And once you find it for a joint derangement diagnosis, care is basically over. We want to finalize a maintenance strategy, prevention plan. I tell people it's not all rainbows and butterflies. These things like to come back. Not always, but in the spine, they like to come back, usually because the spine, we have such dominant positions of our spine in our lifestyles. But patients know that they can use these movements proactively to kind of mitigate symptoms from returning, or they can use them reactively. If the armpit starts to hurt or if the neck gets stiff, you can use these movements. It's up to the individual patient what they want to do with that education, but it's my job to inform them on what we tend to find with patients who have mechanical joint derangements. So if you're suffering from symptoms, especially if they're diffuse, which likely rules in the spine, try to do some repeated movement testing, buying the books and doing your self-assessment, or finding a clinician who implements Mackenzie's work within their orthopedic clinical work, because yes, there are ACL tears and there are other ligament problems and there are fractures and there are tendinopathies, but most patients, I find 70 to 80% of patients have mechanical joint problems that can be fixed by untweaking the joint, moving in a certain direction or two. And I think these patients in other clinicians' hands are getting diagnosed as ligament stuff and, orthopedic stories like impingement and patellofemoral pain syndrome, and getting diagnosed with vague muscle injuries like muscle tightness and muscle weakness. They're missing that the joint is tweaked because they don't know how to apply repeated movement testing.